here at Atlas today. A little different today with Jonathan Sinyard from Adams Drugstore.
Yeah.
Glad to have you here today.
Hey, it's an honor. Glad to be a guest on the show. I'm excited about it.
I think one of the first guys that I probably developed a working relationship with here, kind of outside of the office when I got to town, was you. And goodness, you've been in town now how many years? Back in town?
Gosh, yeah, born and raised here, but back in town as a pharmacist and practitioner since 2009. So 17 years now.
Yes.
It's hard to believe, but it's a fun ride. It really is.
It goes by very quickly.
You know, you were a lot younger when I first came back.
I was a lot younger when you first came back. And I had fewer kids, too.
This is true. Well, I had more hair, so it works.
So it was both sides of that.
Yeah.
But one of the reasons I just wanted to have you on, right, just to be able to talk a little bit about internal medicine and pharmacy, in particular, just some of the interactions that we have. Sometimes my patients have a lot of confusion, right, and there'll be things that they'll ask that I'll tell them, all right, hey, listen, why don't you go talk to Jonathan, go talk to your pharmacist, and let them explain some of this. But one of the questions that I commonly get is, what happens if I miss my dose of medicine? What should I do? You know, it's 8 o'clock at night. I realize I did not take it, my medicine that I was supposed to have this morning. It's now 8 o'clock at night. What is your advice to the patients that come in that have this?
That's a good question, and you're exactly right. It's bound to happen. Even under the best of circumstances, at some point you're going to forget. So the rule of thumb is if it's closer to the time of your next dose, skip it and wait till that one, resume your schedule. If it's closer to time than the dose you missed, take it and double up. So say you take it at 8 a.m. and you think of it at noon. That's fine, go ahead and take it at noon, get back on track tomorrow. But now if it's midnight tonight, hey, you missed your chance, just pick back up tomorrow, sort of thing. So that's kind of the pretty much the safe guideline on there. You know, if it depends on if it's 2-3 times a day, once a day, all that kind of stuff plays into it. But the best case is don't miss the doses. But again, man, it happens.
So if you have a twice a day medicine, right, then you have an easier chance
tighter
to get
window.
back home.
Yeah. And statistically too, the more times it's dosed, once a day versus twice, 3 times a day, the more likely you'll miss doses. From a compliance perspective, that once a day is the sweet spot because it's easier to remember once a day. The more frequent dosing, the more likely you're going to have a forgotten dose somewhere in the mix.
I don't know if there's actual statistics and numbers for it. I'm sure there are. I would just say my clinical experience is the chances of missed doses and non-compliance double every time.
For sure. I agree with that.
Once a day to twice a day, from twice a day to 3 times a day, 3 times a day to 4 times a day.
I think that's a safe bet. Twice a day you can, hey, when I brush my teeth, morning and bed, I can catch it both times. But when you throw that midday dose, it's all out the window. But it's a challenge because some meds have to be, they're short lifespan on them. They have to be dosed 3-4 times a day. So
does it matter what type of medicine? So for instance, somebody who is taking a blood pressure medicine versus somebody who's taking a diabetes medicine versus somebody who's taking, say, an antidepressant or an anxiety medicine. Does the type of medicine matter as to what you would tell them on that?
Sure. So sometimes it depends on side effect profiles. Say if it's a med that's gonna cause some drowsiness, well, hey, let's put it at nighttime. That's a win-win. It's doing its work and it's helping you sleep. You're not having daytime drowsiness. Sometimes they're easy like that. Sometimes they're a little trickier, say like a blood pressure medication that may, last 24 hours. Well, if you're on 3 of them, depending on the structure, it may not be a good idea to have them all at the same time because it's going to bottom you out and then you come back up. So sometimes those get divided out. Statistically with just cardiac issues, sometimes that first thing in the morning is a high risk opportunity. So, some of those need to be dosed at bedtime so they're in your system come morning time. Some meds do better at bedtime, like say cholesterol, the statin medications, some of those need to be dosed at bedtime because when you're sleeping, that's when you're producing the most cholesterol. So you want good blood levels during that time. So a lot of the meds, they're flexible, morning, night, whatever works for your schedule. But there's some of them.
As long as you're consistent with the time.
Consistency is key. And if I had any free advice to give to patients, I'd say, talk to your pharmacist. If in doubt, talk to them and say, hey, is there a certain time to do this? They're a great resource for that thing. So,
okay.
Yeah.
Another question I
Sure.
get. hey, I've got, I'm in town. Can you go ahead and send that medicine in right now? Right? Or can you just give me a written prescription so I can take it over there, right? Electronic prescribing has just changed so much.
For sure.
Since 2009. We very different today than what we were back then when you had to look at my chicken scratch and decide what it meant. I get a lot less phone calls from you now.
Right.
Hey, what did you mean? But that's always the thing that I think that patients, we assume it's like an email.
That's right.
That'll just go straight through. And it's pretty quick, but help our patients to understand a little bit of what happens when I hit the send button.
Behind the curtain. What's happening behind it.
What happens to all this before they can go pick that medicine up.
That's right. So even under the absolute best of circumstances, when y'all hit send, or any provider, when you hit send, there's probably a 10 to 15 minute lag before it hits the pharmacy system. So out the gate, we've got a window we're working with. But then even once it hits, it depends on the volume that the pharmacy's under at the moment. If they're backed up on workflow, if they're caught up on workflow, is it one medicine? Is it 10 medicines? And then even at that point, that's when it really just begins, because when we're filling it, I think one of the biggest misperceptions about pharmacists is, you just put pills in the bottle. Man, just put some in the bottle and just roll with it. But from a healthcare perspective, we know so much more goes into it. When we get that prescription, we're looking, is it dosed right? If it's too low, it's not going to work. If it's too high, could kill you. There's a big variation there. Is it the right drug in general for what we're working with here? We're cross-checking it with patients' allergies. We're looking at drug interactions with their other meds they're on. And then once we get through all those hurdles, then fingers crossed, we submit it to insurance and hope for the best. Insurance creates a lot of muddiness sometimes in the healthcare space when we're looking at what's covered, what's not covered, going through all those hoops. So there's so many steps on there. A good safe rule of thumb is, give it at least an hour on there. But again, that's never a hard and fast situation. If I had a patient, they just left your office, they're sick, they need antibiotics, I just want to get my meds and go home. Hey, stick your head in the pharmacy, check in with us, we'll prioritize it. We'll work on it through pretty quick. And again, part of that comes from just, knowing your pharmacist, knowing the team you're working with, knowing your local providers, because again, we're willing to work with the patient. We're willing to kind of balance everything out to make it flow quickly. But there are so many steps that go through the process from point A to point B.
Well, now you've got a new car, I see, as well.
We just got us a new delivery vehicle yesterday. So we've been delivering. So actually, Adams Drugstore, we're celebrating our 75th year of serving the community of Cordele this year.
You don't look hardly that old.
I know, right? I told you, aging well. So one of the fun things, we've pretty much done delivery from day one, I would say. We've got old newspaper articles where we literally would have like a kid after school come by and pick his bicycle up and throw medicine in the basket and deliver them out.
You don't do that now, right?
We don't do that now. We're a little more sophisticated. But we literally used to go door to door. So it was funny yesterday when I was getting the vehicle, I was talking to the salesman. He made a comment. He's like, man, that's really cool. Y'all are keeping up with the times, with the other guys doing it. I was like, no, man, they're just keeping up with what we've been doing. We've been doing this for decades. But it's a simple service of getting the meds to the patient, some for convenience. So many barriers to healthcare. Transportation's one of them. So if we can eliminate that and get the meds to them, more likely chance of them getting them and using them and actually getting the results they're needing. But we got us a new vehicle, so we should be getting it wrapped and designed and on the road any day now. We're excited about it.
I agree. Transportation's huge issue.
It is.
Right?
It's
like
just
for
little things
certain
that you take for granted. For sure.
We started because of that. We started a home visit program. But I'm afraid Destin's going to be a little bit jealous now because y'all got your own vehicle. She's just using her own personal.
Oh, come on. Tell her Atlas Healthcare needs to step it up.
Apparently we do. Apparently we're behind the times now. So that's all right. So if somebody wants delivery, let's say somebody's sick, they're here, and they want to go home, how would they go about that?
Just touch base with us. So our traditional delivery model is a next day model. So we've done over the years, we still do free delivery for the city limits. We've done everything we can to try to keep it as a free delivery service. Right now, what we're doing is that next day model, just because that allows our drivers to really make their route as efficient as possible. Gotcha. To keep it efficient and keep those costs down. So in general, if we fill it today, we'll bring it to you tomorrow. If there's that same situation, that antibiotic, something you need today, again, call us. 99% of the time we'll make it happen. We'll get it to you today because again, we're gonna prioritize patient care.
As we're working through this kind of list of questions that my patients often have, right? One of the other questions that they always have is, in particular about cost. You tell me how this works because it's so complex. By the time you put insurance companies, the PBMs in there now, and I'll let you explain what a PBM is, and sort of an extra middleman that now wants to shunt things from here to there, and then patients, and then getting it on top of the service that you're getting.
So I would say a patient definitely needs to keep their pharmacy consistent. Multiple pharmacies, multiple doctors, it's just a recipe for disaster. I know you run into that sometimes as we reconcile medications because, as I mentioned, when we're feeling something and looking at those interactions, we can do everything just right. But if we're missing one or two of those meds from a different pharmacy, we don't know all the pieces of the puzzle. So accidents can happen in a hurry. So I would say first, let that driving force be, hey, who is your pharmacy? Use your pharmacy. Let's go from there. But you're right. There can be so much variability in there. Personally, I feel like the independent pharmacies, I know us at Adams Drugstore, we strive to keep our prices as competitively low as we can. And I really feel like across the board, your independent pharmacies are going to traditionally be your best pricing on there just because we have less overhead. We have less corporate, dictating our prices on there. But one thing you mentioned with the PBMs, and a lot of people may not be familiar with that acronym, but Pharmacy Benefits Managers. So those are kind of the middlemen, gatekeepers that say what drug is covered versus what is not covered, how much you will pay for it, how much it'll be at different pharmacies. There's so many variables and they really cloudy that water and it gets really complicated. I know that's the whole topic of this show, but I could go on for days on it, but it gets really complicated when you have PBMs that also own pharmacies, which the big ones do.
Right.
There's the top three PBMs in America touch about 80% of the prescriptions. So they really control it on there. And when they own their own pharmacies, as they do in Cordele, sometimes they make it cheaper at this pharmacy versus that pharmacy, and which is an extremely complicated matter. But we're fighting those battles at the federal level, at the Federal Trade Commission level, at the state level. Laws have to be enacted to fix it, and we're fighting for that. But cost is definitely a variable on there, and that's one of the variables we're looking at when we're going through all those steps to fill it. Everything can check out just right. The right drug, the right dose, the right interactions, everything's good, but it's $500. Well, you and I both know the patient's not going to take that.
Yeah,
So it's just one of those pieces of the puzzle. Cost is definitely a factor for there, and some medications can be very expensive, several hundred. So, one patient, $50 might be a major deal breaker, whereas another patient, $50 might be, that's expensive, but if that's what I need, that's what I need. So we're factoring that in and knowing their situation. Hey, can they afford this? This might be the best drug, but if they can't afford it and they're not going to get it, it's not going to help them. So that factors in as well. But I would definitely tell patients, if cost becomes an issue, talk to your pharmacist, talk to what other options are out there. Sometimes there's manufacturer coupons that can help with some of that. There are some big apps that advertise a lot on TV that are discount, show this discount card at the pharmacy. I strongly recommend against those. I would tell a patient more so, hey, talk to your pharmacy. They can probably, their in-house price is probably cheaper than these, because some of them will say, well, we can save you 85%.
Right.
If you're saving 85%, it was probably overinflated to begin with, which again, we see that a lot at some of those big box stores. But the biggest issue why we kind of steer clear of those guys, we used to do them a lot, but when you look at the fine print, so if a patient comes in and shows their discount card, and when they use it, they're agreeing to the terms and conditions, basically saying that discount card company gets their name, address, date of birth, phone number, medication information, a lot of sensitive information. And some of those folks have been caught red-handed selling that data. And I don't like that. We respect privacy to the nth degree with our patients.
Well, I think, if you're getting something for free, chances are you're the product.
That's exactly right. I completely agree. So I would tell a patient in a hurry, before you just agree to something you don't realize, talk to your pharmacist. There may be cheaper options, there may be other options. Just look at it to see. When I talk to patients about that, I tell them picture if a scam phone call showed up on your phone and you picked it up and they said, hey, can we get your name, your date of birth, your address, your phone number, and your medical information? Well, you'd slam the phone down in a second. Yep. But a lot of times we don't realize that when it saved me $10. At what cost though?
Yeah. So you mentioned something a little while ago that I want to go back to is medication reconciliation.
Oh, yeah.
Now, for patients, right, what a medication reconciliation is when somebody comes into the office, we need to be sure that we know exactly which medicines they're on, exactly how they're taking the medicines, what's going in their body, right? And I think a lot of times when we talk about medication reconciliation, right, between the pharmacy and the physician's office, it can get very difficult, right?
Yes.
Because they've seen 3 doctors, and it's hard to remember sometimes, right?
Is.
Like,
it really is.
somebody will come in, have your medications changed? Well, they forget the sequence of events when they saw the cardiologist versus when they saw us. You know, one medicine was started, one medicine was stopped, and sometimes we'll adjust the medicine, thinking that they're still on this medicine when it's been changed. When
That's right.
Perhaps we haven't gotten the note from the cardiologist. Most of the cardiologists are really good about it, but again, that exchange of information we were promised with electronic medical records, it's just not come like we think it should have, you know, from 12 to 15 years ago. Maybe it'll be better in the next 12 to 15 years, but the reality today is, for me, understanding, one of the hardest things that we do is to understand exactly what patients are taking, especially when there's multiple doctors involved, right? Like, and even sometimes, right, when we're the only one involved, right? Because we may say stop a medicine, but the patient gets home, maybe they're elderly, maybe, you know, something happens, that bottle's still in there, and so sometimes we'll have them bring the medicines in. But I just know, like, sometimes I've prescribed a medicine thinking this is the right medicine, and then you'll call me and go, hey, did you also know, by the way, that they are on this other medicine that interacts with it? I'm like, no, I didn't know that. But so your recommendation is to stick with one pharmacy, right? What about, you know, what tools would you recommend for patients when they're going from physician to physician that's helpful for them in that medication reconciliation? To be sure that all the physicians know what they're taking and what's going in their body.
I would say a simple thing, just keep a running med list. You know, even if it's just like a little wallet card that has all your drugs on there, or if in doubt, swing by your pharmacy and ask them, hey, can you give me a printout of everything I've gotten for the last 3 months, 6 months? It takes 10 seconds. But that one step can sometimes make a huge difference, because you're right. They may see something on there that doctor might say, oh, well, I didn't realize they were on blank. I don't need to prescribe blank. You know, that sort of thing. That's a quick and easy one. You know, just communicating. You know, say if a patient comes to your office, you know, you guys are really good about communicating it over to us. Like, hey, we're stopping this, we're starting this. But even if nothing else, when the patient comes in, you know, if you leave your provider's office and swing to the pharmacy, tell them anything new. Yeah, hey, they just stopped my such and such today. Just communicating, you know, it goes a long way. And I would definitely say, when we talk about having the one pharmacy, to me, that's one of the valuable pieces of the puzzle. Like in a local town like this, working together, collaborating as healthcare providers, that connection point there, because just like you mentioned, you know, there may be something we're feeling, and it's like, hey, did you know the patient's also on such and such? Well, no, I didn't. You know, there's that connection that, say with a mail order pharmacy, there's that disconnect there, you know, or when you're having multiple pharmacies and they don't know all what's going on. So to me, that relationship of knowing your healthcare providers, knowing your doctor and their team, knowing your pharmacy and their team, knowing all those people and having connections, it really can make it a lot safer, because it can be complicated. You know, we always hear about medication errors happening and the problems they create. Even under the best of circumstances, they can still happen. You know, I was talking with some of my pharmacists just the other day. You know, you can have a patient that's on 2 drugs. You know, they've been on these same 2 drugs for 5 years. They work perfect together. Well, every drug that comes into our bodies metabolize it and get it out, just like food. You know, we digest our food and it gets out. You know, we metabolize those drugs and digest them and get them out. Well, they all affect together. Say they're both going through the liver to be filtered. If you've got 2 drugs that you've been on for 5 years and they work great together, they're kind of working well together. Well, then all of a sudden, if the doctor says, hey, drug B, we're going to decrease it by half. You know, we need to cut that dose down. Well, if it was affecting drug A, now drug A may start building up in your body because of how they work together. And we counsel our patients, especially say our chronic pain patients that are on narcotics, because they work great like they're supposed to when they're being taken properly. But then you change one medication and all of a sudden you hadn't changed the other dose, but it can begin to accumulate in your body. And you can have problems on your hands, you know, say with a chronic pain narcotic or even a blood pressure medicine. It can bottom out your blood pressure in a hurry, you know. So they work together in so many different ways that it's critical to make sure the pharmacy knows what all you're on, what all you're not on. Make sure your provider knows what all you're on and not on, just so we can kind of minimize these risks.
Any questions for me?
Ooh. What would you say to the average? I know you and I have a phenomenal relationship. We can work together. We talk together a lot. But what would you tell just the average pharmacist? Like, this is something from the doctor's office that would help us help each other, sort of thing. What kind of?
Yeah, I mean, I think that one of the things that I've appreciated about our relationship, right, is the open communication, right? That if something doesn't look right, that it's easy enough to say, let me communicate with the doctor really quickly, because they're our patients, right? We want to take care of them.
Yeah.
And I will say this, when folks come and ask and they say, well, hey, I was like, listen, the one thing I can say about Jonathan is he will aggravate the stink out of me if he thinks something's not right. But that's what you want.
That's right. Yeah.
Right. I mean, that's what you want from a patient care standpoint, is he's looking over it. And I think, we do have a lot of good pharmacists here in town and pharmacies, but to somebody who is coming into the pharmacy industry, what I would look and say is just that open communication, right? Like, no longer can we practice medicine in a little bubble, right? It has to be a team, right? It has to be a team approach, and that, viewing yourself as being on that team is really important, whether it is as a front desk receptionist, whether it is as kind of going through as people on our counter, right? From the front desk to the MA to the provider to the checkout process to the pharmacist to the lab technician or the radiology technician, right? We all have to function together because we all have a common goal.
That's right.
The common goal is patient care.
To take care of patient. Yeah.
And take sick patients and make them better, right? To take patients who are not sick and keep them well, right? And that would be probably the only advice that I would have that I could say would be just universal. Is play on a team.
Yeah, and I like that. Like, I mean, you hit the nail on the head, that team approach. Like, at the end of the day, the patient is the center of the wheel with all these spokes coming out. We're working towards caring for that patient, how to maximize their health care and get them to the goals we're looking for. That's huge right there. And you mentioned our relationship and just the connection and the trust and dependability we have within one another. That's something we don't take lightly, with that trust, because we're entrusted to care for our patients. I had a patient just the other day, we were sitting down talking, doing compliance packaging, a consult on that for blister packs, how we do the blister pack program to help adherents, where we sort their meds. And as I was talking to him, I didn't know this patient. They'd never come to our pharmacy before. And I asked myself, how did you even know we did this? And she said, well, over at Atlas Healthcare, they told me to come talk to y'all that y'all could help me with this. And while I appreciate the referral, it was the trust that was involved in that. It was hey, you need assistance with this. You go talk to Adam's Drugstore. They will help you with this. And that there's a tremendous value in that, to know that at the end of the day, we're working towards the common goal of helping that patient. There is no tension. It's just it's a smooth process. I wish every provider could mutually work together like that in that situation, because it definitely works well.
Absolutely.
Yeah.
All right, we've talked for a long time.
Well, we did. That was good.
Go dogs, seek 'em.
Go dogs. Love it.
Do you know where the seek 'em comes from?
I assume it's just telling the dog to attack, like sick 'em. Do tell. I feel like you might have liked me on something.
So you know that at the University of Georgia, they train gastroenterologists. So when gastroenterologists do the colonoscopy and they get to the very end, where the appendix lives, the last part of the colon is called the cecum.
There you go. So that's where it comes from. Love it.
Sorry. Dad jokes are a thing.
Oh, it's becoming one of my specialties. Yeah. I love it. I annoy my kids with it, and I could not be more proud of it.